So the topic that Sanjay has given to me is, let's say, interesting, but at the same time, it makes us open up many doors and makes us think quite a bit as to whether PGT is for all. Now we can interpret this in two ways. Two ways is, should everybody do PGT? Should all IVF centers have PGT? But the interpretation, I think, what IHERA meant was that should all patients, irrespective of the age, their obstetric history, their infertility status, should everybody undergo PGT? Now, I am a proponent of PGT, but I would also like to be the devil's advocate and give you both points of view, because both sides are valid. Let us just consider for a while some of the advantages and disadvantages that all of us know very well. Now, we know that if we do PGT, we are doing a deselection of embryos so that the risk of having an abnormal baby comes down. It is also used widely for unexplained miscarriages and for women who have now born a child or a baby who can be genetically abnormal. Having a termination can sometimes be very drastic. Now, if you look at data, PGT by and large will not increase the overall chances of baby. Yes, PGT will increase the implantation rates, pregnancy rates per embryo. But if you look at the cumulative pregnancy rates or the intent to treat, PGT will not offer many advantages. PGT may be expensive, but this is debatable. At the end, towards the end of my talk, I'll show you why it is actually time saving and money saving. Yes, if you're not well versed with embryo biopsy, they may not survive the procedure, and due to technical challenges, which again we'll talk about a little later, I will show you why it may not reflect the true health of the embryo. Yes, above the age of 36, PGT definitely decreases the time to pregnancy and decreases the miscarriage rate. But on the other hand, we have this bugbear of Mosaicism. And there are many interpretations of Mosaicism, again, which we will touch upon. We should also be careful of interpreting false positive and false negative tests. If the embryos are not well cryopreserved, they may not survive the thawing, and then the entire cycle may get wasted. I love this paper by Dr. Belver. It's in RBMO, and it is a very interesting paper. It deals with a SWOT analysis. And if you see the levels of evidence, the type 1A is the best type of evidence. Just look at this slide closely. I'll wait on it for a little while. In a SWOT analysis, you want to look at what are the relative strengths and weaknesses of a study. And again, depending on what technique or technology or platform is used, one may get better results. Most of us today will use the PGM NGS platform, which is the most critical and best way of analyzing embryos. Now, I'm going to leave this slide on for a little while. The SWOT analysis consists of 4 points. The strengths, which is the positive, the weaknesses, which are negatives, the opportunities that the study provides, and the threats that may be present in the study. Belver did a thorough analysis and came up with this evidence, which you can look at and study. And the conclusion that was drawn is that it is very important to discriminate between a euploid and an aneuploid embryo, because in a way, if we transfer embryos which are not tested and therefore have a practically zero probability of implantation if they're aneuploid, they will either result in a gestational loss or even worse, result in a gestation which has a chromosomally abnormal embryo. I love this discussion by David McCullough. He is part of the NYU Fertility Center, and there is some amazing thoughts that he has expressed in his symposium, and all these slides are directly from his symposium because I did not want to take out the essence of the talk. So there are very few RCTs, but there are 3 RCTs that are always spoken about: Yangs, Scots, and Foreman. And most of the concepts that we have about PGT, as it is now called, are based on these 3 papers. And these prospective randomized trials all had different groups, but each one of them showed that the clinical pregnancy rate was much better in PGT cycles. They showed a delivery rate which was higher, and also they showed that when you are transferring PGT tested embryos as versus a single embryo transfer as versus a double embryo transfer, if it is PGT tested, then it will have a very high ongoing pregnancy rate. Also, the multiple pregnancy rate comes down, which is very important for IVF patients. So, again, to summarize, all the 3 RCTs showed advantages of using PGT. He also went ahead and used a larger data set from the SARC data and looked at data which compared PGD to no PGD, as it was called earlier in 2017. He summarized that if the number of patient cycles examined was much larger, in this group, there were 2 groups, PGT versus no testing. Those who were not tested, there were 30 to 110% more embryos transferred. And that means that more cycles had to be done. That also means that there could be more multiple pregnancies. And the benefits that McCullough showed was that there was an increase in live birth rates, a decrease in the spontaneous miscarriage rates, and decreased premature deliveries. So all these benefits could only be realized with PGS. So this is a slide which should sum it all, that whenever you are looking at data, looking at PGT tested embryos, do not just look at pregnancy rates, look at what happens to the patient when she's trying to conceive. So you have to look at the cumulative pregnancy rates, you have to look at the spontaneous miscarriage rates, you have to look at the premature delivery rates, and so many other things, which as the pregnancy evolves will reveal itself. This again was a beautiful presentation with David Brooke Hodesworth and Jamie Griffo, and again this I would like you to look at it because it tells you that preimplantation genetic testing for aneuploidies or ploidies is definitely cost effective. Again, all these are taken straight from the talks because these are beautiful slides. So at their center, they examined patients from a certain period of time, from 2011 to 2013. They looked at IVFs, they looked at the subsequent FETs, either with or without the use of PGS. And they did not at this point look at the cost. They only looked at the overview of outcomes. And they found that the number of embryos transferred in the PGS group was significantly less. The clinical pregnancy rates were higher. The spontaneous miscarriage rates were lower. And there were no multiple pregnancies in the IVF PGS group. Now, very good slide, and it really sums up when many people will say, oh, PGT is so expensive, you're adding on to the cost of the patient. So they divided the costing as per the age. And look at the last 2 columns, and you will see that cost per delivery when there was no PGT used and cost per delivery when PGT was used was the same for somebody who was less than 35 years old. And in fact, at the age of 40 to 42, the cost came down. However, above 42, the cost went up because the woman had to undergo multiple cycles to get a euploid embryo. So they concluded that for patients 42 years or under the cost of PGT is equal to or less than not doing PGT. So please bear this thought in your mind that the utility of PGT is much more and the costing is equivalent or less. So they showed that yes, PGT is cost effective, and it is important, they said, to discuss PGT with all patients and give them the benefit, help them to make choices. And of course, we must learn to proceed with patients' desires. Okay, there is, most of you would have heard of Norbert Gleicher. He is a brilliant academician and he has done a lot of work and research into PGT. And it's important also to listen to the other point of view because one can learn a lot. There are plenty of papers which I'll show you, and what he said that if you do a single trophectoderm biopsy and mathematically you calculate, it is not possible to determine the embryo ploidy accurate enough to use it for clinical purposes. Richard Paulson, another very academically sound person, a great scientist and researcher. Let's see what he has to say. So he says that PGS is inherently imperfect. Means there are things which are inbuilt, which will give some problems in analyzing whether PGT is helpful or not. Today, Mosaicism shows us the greatest problems. And most of the Mosaicisms are mitotic in origin. So, and we are just looking at 5 to 6 cells at the most when we do a trophectoderm biopsy. Therefore, the biggest worry that we face and the biggest question that we have to answer is that when the report comes back aneuploid, are we going to discard this embryo based on the report? And in our program, what we do is we do not discard abnormal embryos. We save every single abnormal embryo because as the PGTIS statement will evolve and as we see what is happening to the fate of abnormal embryos or mosaic embryos, we will see later that there are so many pregnancies that have resulted from using the so-called aneuploid embryos. So some programs may discard as high as 40% of tested embryos because they have been claimed to be aneuploid. But every program needs to look at what is their aneuploidy rate, what is their negative call rate, are they doing the biopsy properly. So this will tell us what are the efficiencies in your particular program. This is a beautiful paper which shows that when so-called abnormal embryos were transferred, they did a worldwide web-based study, and initially there was a lot of confusion because based on the PGDIS International Modified Reporting Guidelines. So it's the first time in 2017 that they said that it is possible to selectively transfer mosaic embryos. There's a lot of confusion because some people said that your cutoff should be 40%. Some said that anything less than 20% in mosaicism is fine. Some people said no, even up to 80% is fine. So there was no clear-cut line to demarcate whether a mosaic embryo should be transferred or not. Till 2016, there were 200 live births which were already reported, of which they were mosaic. However, by a little later on, by about say 2018 or 19, about 400 such babies were born worldwide and these were normal when so-called abnormal embryos were transferred. I'm sure the figures of normal babies now being born when we transfer abnormal embryos must be more than 500 by now. The other interesting fact that Gleicher showed in 2 articles is that the miscarriage rate was very low in these so-called abnormal embryos. So how can we explain that the report has come back abnormal? This embryo has been transferred, but very less chance of miscarriage and very high clinical pregnancy rates. So this is something that we have to explain to our patients. So Munde has a very large database, and as you know, what they have said that there can be a 50% ongoing pregnancy rate when their team has transferred embryos with single monosomies and single trisomies. They've even transferred some complex multiple chromosomal abnormal embryos, and they are still seen a 10% ongoing pregnancy rate. Another paper by Morales showed that there was a very low rate of miscarriages resulting from such transfers. So mathematical modelings were done, and Gleicher again showed something very interesting, that if you just take out 5 to 7 cells from the trophectoderm, and normally all of us will try not to take out too many cells. If you take out too many cells, then you may always get a positive report, and if you take out too less cells, you may get a no call rate, meaning that the analysis could not be completed. So we try to take out between 5 and 7, but what Gleicher showed by a mathematical calculation, that if you want to have a good reporting, you need to take out at least 28 cells from an embryo. Now none of us would like to do that. Also, there is a theory of self-correction, which we all are aware of. Sometimes we will see at the blastocysts few cells trying to come out. Perhaps those are the ones which are self-correcting and getting apoptosed and coming out. So all these things have to be kept in mind. Also, there can be many false positive as well as false negative results. And this is reflected in sometimes the very high pregnancy rates and live birth rates when abnormal embryos are being transferred. Also, we have to look at the ethics of the whole problem. Are we right in discarding embryos or not transferring embryos which have been labeled as aneuploid or mosaic? The problem of mosaicism is always there. It will depend from where we are diagnosed, where we are doing the biopsy of the trophectoderm cells. If we are taking too few cells, and if those turn out to be mosaic, we'll get a report as mosaic or aneuploid, depending on what the DNA content is. So this is one area which is very difficult to navigate. So let's see the last slide where, and again very beautifully explained, look at the dotted lines, which is pregnancy per embryo, and then look at the straight line, which is the cumulative pregnancy chance. If you look at this, you will see that as your culture progresses, your cumulative pregnancy rates, as will you see with the straight line, start coming down. And therefore, the question still arises that are we justified in taking all our embryos to blastocyst stage? Are we justified in doing PGT for all? Friends, I thank you for a very patient hearing, and I'm so happy to present some of my views in this wonderful conference. Thank you and God bless.